Hello, I'm Zach Smith, faculty member in the Division of Gastroenterology and Liver Disease at University Hospitals and assistant professor of medicine at Case Western Reserve University School of Medicine in Cleveland, Ohio. Prior to joining the faculty here in 2017, I was a fellow in interventional and pancreaticobiliary endoscopy at Washington University School of Medicine in St. Louis. While there, my colleagues and I conducted a randomized controlled trial which has recently been published in gastrointestinal endoscopy. On behalf of my co-authors, I wanted to thank the editorial team of GIE for offering us the opportunity to discuss our paper today. Our study is titled A Randomized Controlled Trial Evaluating General Endotracheal Anesthesia versus Monitored Anesthesia Care and the Incidence of Sedation-Related Adverse Events during ERCP in high-risk patients. The most recent ASGE guidelines recommend that anesthesia services be considered in all complex endoscopic procedures. Anesthesia performed for ERCP is usually done either with deep sedation without an endotracheal tube, so-called monitored anesthesia care or MAC, or general endotracheal anesthesia, so-called GEA. Despite this guidance from ASGE, there is no current standard of care with which anesthesia is administered during ERCP. Many sedation-related adverse event risk factors have been identified in patients undergoing GI endoscopic procedures. These include, but are not limited to, male sex, elevated BMI, and high ASA class. In these patients, with regard to ERCP, it is not clear whether MAC or GEA is a preferred method of sedation. Therefore, the primary aim of our study was to determine the effect of airway management, general endotracheal anesthesia versus MAC during ERCP, and the effect on sedation-related adverse events in high-risk patients. Secondary aims included therapeutic success, procedure-related adverse events, and endoscopy unit efficiency metrics. This was a single-center, randomized, controlled trial. Patients were eligible if they were undergoing ERCP and had at least one established risk factor for sedation-related adverse events. Patients were excluded if there was an emergent indication for the ERCP, if there was an unstable airway as assessed by the anesthesia professional, if they had had a prior tracheostomy, if there was clinical or imaging evidence of delayed gastric emptying or gastric outlet obstruction, if they had altered foregut anatomy, if they were undergoing endoscopic ultrasound preceding the ERCP for tissue acquisition, if they were a pregnant female, or if they were unable to provide informed consent. All procedures were performed by one of 4 interventional endoscopists with or without the use of the interventional endoscopy fellow. All procedures were performed in a semi-prone position. The primary endpoint of our study was the incidence of composite sedation-related adverse events, defined as any of the following shown on this list. Secondary endpoints included patient room-in to room-out time in the ERCP suite, so-called room time, total procedure duration, time to cannulation of the duct of interest, technical success of the ERCP, and immediate and delayed procedure-related adverse events. In total, 231 subjects signed informed consent to participate in our study from July 2016 to November 2017. 31 subjects were subsequently excluded. 101 patients were randomized to the general anesthesia arm and 99 patients to the MAC arm. Seen in this table is the baseline characteristics and demographic information for our study subjects. As you can see, the 2 cohorts were well matched, aside from slightly higher stop bang scores in the general anesthesia arm. This table outlines the composite sedation-related adverse events for our study population. As you can see, there were no statistical differences in hypotension or cardiac arrhythmias. Not unexpectedly, hypoxemia and airway maneuvers occurred at a significantly higher rate in the MAC group compared to the general anesthesia group. Perhaps most importantly, 10.1% of patients in the MAC group ended up being converted to general anesthesia during the procedure, either for a significant amount of gastric contents which were retained or due to respiratory instability. With regard to the secondary outcomes, there were no differences in cannulation of the desired duct, cannulation time, procedure time, fluoroscopy time, or room time between the 2 cohorts. Similarly, the Aldrete scores were similar between the 2 groups when the patients were brought to recovery. With regard to procedure-related adverse events, there were no immediate adverse events noted related to the procedure. However, 10 delayed procedure-related adverse events were observed, including 6 in the MAC group and 4 in the general anesthesia group. The results of this study provide robust evidence regarding the use of anesthesia during ERCP in patients who are high risk for sedation-related adverse events. We did not observe any statistically significant difference in procedure time, cannulation time, or fluoroscopy time between the two cohorts. Importantly, 10.1% of the patients in the MAC group ended up being converted to general anesthesia either for a significant amount of retained gastric contents or respiratory instability, which was refractory to airway maneuvers. With regard to the primary endpoint, again, sedation-related adverse events were higher in the MAC group compared to the general anesthesia group. However, this was primarily driven by the incidence of airway maneuvers and hypoxemia in the MAC group. We certainly acknowledge that there are several limitations to our study. Specifically, this is a single-center design in a unit which is high efficiency with high volume. Our anesthesia staff is extremely experienced providing anesthesia for advanced endoscopic procedures, and therefore units with anesthesia personnel who are less experienced in endoscopy may not experience similar results. All general anesthesia patients recovered in the recovery unit of the endoscopy center and not in a postoperative anesthesia care unit. We also recognize that this is not the case in many centers, and oftentimes patients undergoing general anesthesia will be recovered in a PACU, which may affect unit efficiency. To conclude, the use of general anesthesia during ERCP in high-risk patients resulted in lower rates of sedation-related adverse events. This was primarily driven by the high rates of hypoxemia and the use of airway maneuvers in the MAC cohort. There were no statistically significant differences in technical success, procedure time, patient recovery time, or endoscopy unit efficiency. The results of this study suggest that general anesthesia should be the preferred method of sedation in ERCP for patients who are high risk for sedation-related adverse events. We look forward to the results of a larger, multi-center, randomized controlled trial, which would add credence to these results and help improve the generalizability of these findings, especially with regard to unit efficiency metrics. Again, to the editorial team of GIE, on behalf of my co-authors, we want to thank GIE for offering us the interview today. Thank you.